So, all right. Good morning, everyone. Welcome. Can you hear me? No.
Hear you loud and clear.
Yeah, they hear you. You can hear us, Andre?
Clear, you kind of do good.
That's interesting. Let's try. This. No. So can I hold it and then he can clip it? Okay. All right. All right. Good morning, everybody. Why don't we go ahead and get started? Thank you all for coming to Grand Rounds on this rainy day. I'm really excited for our speaker today, Dr. Ben Israel. Before I introduce Ben, Dr. Rockbeisel has a couple of announcements she wants to go off of. Please say aloha to her.
Aloha, everyone. This is my first day back. It's hard to believe that I was sitting in 84-degree weather on a beach yesterday, just basking in the sun. And I had to drive to work in icy rain. It was wonderful. So anyway, it's great to be back. I said to my husband the day before yesterday, I said, I'm ready to go home. I got to get back to work. So this has been great. So welcome everyone to Grand Rounds. I just had a couple of announcements. I just wanted to remind folks that, we have a faculty meeting every other month. So we have a faculty meeting in January. I want to say it's the second Thursday of January. I want to say it's the 12th. I don't have a calendar in front of me. It is in person. And we will have the CEO of the medical center, Dr. Bert O'Malley, with us that day. You remember, I don't know, 4 or 5 years ago, for those of you that we had Dr. Mohan Suntha join us, extremely informative and enlightening. And so Dr. O'Malley is going to join us. Just came from his office. He would like to know ahead of time, what are our 5 biggest challenges that we face? And of those, how can we partner together with him to solve them? So I know if I went around just the room right now, we'd have 20 big challenges, right? So it'll be my job to whittle us down to 5. But what I ask everyone here and remotely to please forward to me if you have a big challenge, clinically, educationally, or research, to forward it to me. And then I will try to look at many of them may be similar. We'll consolidate them down. You could talk at your division director meeting, come up with maybe some suggestions, forward them to me. I want to give him 5 of our biggest challenges that we could partner with him to solve. So I appreciate that. Again, we'll have lunch. It is in person and it's here in the campus center. So I look forward to that meeting. And I think that's really all. So I'm going to give you back to Chris and he's going to do the introduction.
Okay. Thank you, Dr. Rockbeisel. So today we are delighted to have Dr. Ben Israel presenting Grand Rounds on trauma-informed care. Ben is a clinical assistant professor at the School of Medicine, where he works at a number of clinical sites, including addiction psychiatry, HIV psychiatry, and emergency psychiatry. His main clinical and academic interests are in the evaluation of treatment of individuals with complex trauma and trauma-related syndromes, as well as the implementation of trauma-informed care. Last July, Dr. Israel helped to open a trauma-focused outpatient psychiatry clinic within the Division of Addictions Research and Treatment. And he is also the lead author of a recent critical review exploring trauma-responsive addiction treatments. He has a private psychotherapy practice where most of his patients suffer with complex post-traumatic and dissociative syndromes. He has presented to professional audiences locally, nationally, and internationally on on the diagnosis and treatment of complex post-traumatic syndromes. And he also sits on the board of directors of the International Society for the Study of Trauma and Dissociation. He is contributing to upcoming treatment guidelines and advanced level psychotherapy training, focusing on the treatment of complex post-traumatic syndromes. Prior to joining us at University of Maryland, Dr. Israel served as the service chief at the Trauma Disorders Program at Sheppard Pratt. He is a graduate of the University of Pittsburgh School of Medicine and completed his residency at the University of Maryland Sheppard Pratt program. Ben lives in Baltimore with his wife and their 2 sons, and I'm pleased to introduce Dr. Israel.
Yep, whatever pocket is good. Thank you. Thanks, David. Thanks for the kind introduction, Chris, and thanks everyone here and in the cyberspace who's joining. It's really such a huge honor of my career to be here and to come and speak where I lived and trained and trained and in many ways grew up not all that long ago. My hope, Dr. Rockbeisel, who I think I saw you for the first time in person finally today after you hired me. So I'm really grateful you hired me and we got to actually meet finally in person. I would, this talk may be timed well for your conversation about the questions, because maybe trauma can be one of the big challenges clinically, educationally, and systematically that we could think about. I realize not everyone thinks about it in the same way, so I hope this talk can at least illustrate how I think about it. I have no disclosures to make. Last year, we had a grand rounds as part of our diversity, equity, and inclusion series that really highlighted how important it is to discuss the concept of physicianality. And I don't know if I'll do as clear a job as she did, Dr. Lega did. But I wanted to just acknowledge a few things. Trauma is a hot topic in lots of places, and it's a charged topic. Most people have reactions, even to chalk talks about the basic theoretical nature of, and I've had mine. I also come from a place of enormous advantage, biographically, geologically, educationally, and in just getting dumb luck and landing here and finding wonderful people to train. And to get messages through my own thick skull about how to think more clinically. And my goal in talking about this subject today is to try to step out as much as I can from bias and prejudice that my own background and training may bring to this topic. It is really, I think, impossible to cancel those things out. We can't cancel bias. We can't cancel. So in thinking about trauma, I'm reminded of a quote, a fairly recent quote from Tom Ensign, the former director of mental health at NIH, who said, we spent about $20 billion at National Institute of Mental Health during my tenure from 2002 to 2015. During those years, the US suicide deaths increased about 30%, and the disease-adjusted life years for mental illness increased about 40%, with more people with severe mental illness incarcerated and homeless. Um, One of the ideas I'll propose to our group today is that maybe trauma has a role in the problem and in possible solutions, individually, systematically, and even on a macro, a social, structural level that Dr. is thinking. I'll also be discussing how big the opportunities for addressing trauma in psychiatry are, because our field collectively, historically, has largely been dealing to issues of traumatic stress and related syndromes and experiences. I'll talk about that briefly in a short while. Another quote I wanted to raise is from the artist Vic Mensa, Wyclef Jean, who published a song early in the pandemic called Shelter. Here are a few lines. Hospital workers in scrubs with no PPE, but they got money for their riot gear. We dying here. You tell me not to move with my gun, but we got more funeral homes than schools where I'm from. On the news, all you view is homicides. But tell me why it ain't no trauma units when everybody's traumatized. And as you may know about me, I have a soft spot for anyone talking about trauma units. That's a public health issue in and of itself. Psychiatry trauma units. But really, they're singing about public health. They're talking about PPE and infection control, riot gear and institutional betrayal with police, gun control, trauma that happens at schools and burying family members too early. And this is the scope that trauma-informed care involves. It is massive. It's more than I can understand fully yet. But I think it's more than any one person can really take on their own. It has to be a team, and it has to include engagement across all levels of an institution and across different organizations. We're hearing about trauma more than when I was in training. We're hearing from social movements like Me Too and Black Lives Matter. We're hearing from media events. We're hearing about Prince Harry and Meghan Markle discussing the experience of being harmed in the royal family. We're hearing about wars, obviously, not just the war in Ukraine. We're hearing about refugee crises, not just from Ukraine. Venezuela is another hot spot now. We're hearing about trauma from mass migrations, legal cases, Harvey Weinstein, Bill Cosby, most recently Johnny Depp and Amber Heard. These are all about trauma, and they are breaking the surface of the news like I never remember even in my, even 10 years ago. There have been public investigations into traumatic stress, not so much in the US, but in Australia and the United Kingdom. The government of Australia recently apologized to victims of institutional trauma who were treated in their hospital system. The United Kingdom just released a massive investigation about child sexual abuse that I think everyone should know about, because it's common. In psychiatry historically, we know about it from our patients, but we've struggled to accept it to the point where we train people that it's common. As I mentioned, trauma is not the only challenge we're dealing with in this systemic level problem. We have a deficit of CMHCs. This was a big article in the New York Times. Many people may have seen it because I think it was forwarded to me 2 or 3 times. And there are needs on every level. So I want to just acknowledge that I'm aware that trauma isn't everything, despite my focus here and in other places. I hope that this discussion can help illustrate just a piece of a much bigger. Here's a case example from psychiatric emergency services where I live Fridays during business hours. Patient Donna F. This is a typical case. There's a version of Donna F. Most times when I'm 39-year-old African-American female. Chief complaints, depressed, suicidal. She'd been hurt by her partner recently. She had carried past diagnoses, numerous, selected here, schizoaffective disorder, bipolar disorder, cocaine use, opioid use disorder, sedative hypnotic use disorder, benzodiazepines. She had been first hospitalized at 11 years old, but many times after, she had tried about 24 psychotropic medication trials, including antipsychotics. She was a girl. Her first medication trial was at 8 years old. She wasn't sure if she had had concussions before. She suspected that intimate partner violence may have led her to experience concussions. She interestingly had been treated in the past both for tuberculosis and recent monkeypox. Numerous suicide attempts, cutting, hanging, overdose attempts. Just briefly, social history, very complex. She was raised mostly in the foster system, completed 10th grade. She's currently homeless. And when I met her, she mentioned she was really depressed since childhood. She hears voices since about the age of 8 when she had this medication trial. She occasionally sees deceased family members, even though she knows they're dead. She described a couple of episodes that past psychiatrists thought might be manic episodes. They lasted, though, she said, absolutely no longer than 2 days, usually just a few hours. And this all started before she started using drugs and struggling with addiction, and also occurred during periods of sobriety. On exam, she was disengaged. She was goal-directed and linear in her associations. And when I asked her, she said, yes, I'm hearing that chattering noise and presence in my mind, but it's not really, distracting me. I can talk with you. She didn't endorse it. She wasn't reacting overtly. This is a pretty typical case presentation in PAS. And honestly, this is the kind of case, and many like it, that have led me to feel helpless here. One thing that I have come to appreciate since the University of Maryland is how humble I've got to be. I came from treating patients where trauma was really the one major problem, and medical psychosocial problems were not really an issue, and that was a high threshold environment for treatment. In a low threshold environment, the scale of medical problems, psychosocial problems, brain injuries, developmental problems, lack of education, and substance use, misuse, and addiction, they often take the cake, and trauma rightly is not the first thing we need to address. It took me a few months to really understand that. It helped me, I think, realize what was really happening, not just is someone still learning trade as a psychiatrist and therapist in a large health system. This is humbling stuff, and I feel helpless on a regular basis when working with patients. It's typical presentation. So I want the case of Donna to stick as much as possible in people's minds. We'll come back to her. Her case illustrates a number of the systemic problems we'll be discussing. So to define trauma-informed care, we need a definition of trauma, which psychiatry hasn't really worked on very hard. We need to differentiate trauma from adversity. What is really the difference? We'll identify some differences between trauma-informed care and specialized treatment for trauma. No one ever taught me that, by the way. I had to figure that out when I came here because I thought everything was both. We can describe reasons why trauma-informed care has to incorporate not just individual interventions, but systematic ones, leadership perspective, organizational psychology, public health perspective. What model of quality improvement makes sense in trauma-informed care, if you're interested in being, in making a meaningful change, even one piece of a system. Finally, let's identify one evidence-based practice that can make a clinical service more trauma-informed overnight. And the answer is screening, which we'll talk about more soon. This slide looks like pictures from the Vietnam War, because it is. We have soldiers, fatigued, demoralized soldiers on the left. On the right, that's actually in 1968, a Viet Cong prisoner being prepared for interrogation. I want to say these pictures are also about something else. These pictures were taken 12 years before psychiatry acknowledged that trauma causes problems. PTSD didn't exist until 1980. And the reason is a little bit of a story. I had slides, but I had to take them out for time. The reason, why the Vietnam War? We had shell shock in World War II. In World War I, we had combat fatigue in World War II, which was responsible for a quarter of combat casualties, combat fatigue, and almost 1.5 million veterans after World War II were treated for some version of combat fatigue. We were treating this, though we weren't acknowledging it or naming it. We had other wars. We had domestic violence had been invented before 1980 as well. Why wasn't it named? And the history is a little bit of a longer story, but the essential thing to remember is that psychoanalysis started out as a trauma. Freud's second volume, Studies in Hysteria, his original theory, his major first real theory of psychoanalysis and theory of the mind was called seduction theory. And it was about essentially family members sexually molesting and abusing children. For a variety of reasons that are outside the scope of this talk, Freud did a complete reversal and psychoanalysis he dropped the study of hypnosis and he focused on free association and repression and fantasy. And his greatest works follow the interpretation of dreams, his description, structural theory of the mind, and the Oedipus complex, fantasy theory. Dr. Miller, I'm not going to try to go too much further because I know I'm going to make some errors. Try. But what happened in psychoanalysis is also interesting and paralleled something that happened much later. The psychoanalytic community started to punish people who really did try to look at trauma in their practice. By far the most famous example was in the early 1930s. One of Freud's top disciples, Sandor Ferenczi, gave a talk about it. He was excommunicated completely and called crazy and a quack by the psychoanalytic community. And he happened to die a couple of years later from a blood dyscrasia from, I think it was pernicious anemia. And the analyst said, see, I told you he was crazy. He had a blood dyscrasia. Okay. The other thing about psychoanalysis that we have to understand and remember is that psychoanalysis ruled psychiatry from the 1940s to the 1970s. Every major department chair, for the most part, was a psychoanalyst, and that was the way to have prestige. So we had a culture that started after a major reversal in the 1890s that didn't really change until the 1970s. I actually like psychoanalysis, so I want to be clear. I am not attempting to make a knock, but I want to the people who think about the mind the most can have blind spots. And we didn't have trauma disorders until 1980 when the media started showing up to wars. Okay, that is how it happened. And there was a political movement, and finally people had the political capital to research this idea of post-traumatic stress disorder. There's a post-history too. PTSD is a diagnosis for Vietnam War veterans. It is one of many multifaceted, heterogeneous presentations that trauma disorders take. It is basically a diagnosis for people who had safe childhoods and then got hurt later. Flashback intrusions, flashbacks, nightmares, mood swings, phobic avoidance, mood disturbance that affects your functioning. That is the typical presentation for someone who grew up relatively safe, but then got hurt later once their brain had formed and matured. Most people with trauma epidemiologically, and I'll show you some data soon, don't quite fit that picture. So PTSD is both overdue and it was outdated when it was written down and inscribed in the DSM-3. So this is one of my kids' books. You can actually build the construction site in your imagination by doing these different movements on the book. So maybe one day I'll tell them about what happened to their book. What do we need to build trauma-informed care? This is a systems level problem. Well, we need operational definitions of trauma and trauma-informed care. I propose to this group, psychiatry has never had an operational definition of trauma. We need a healthcare system. We need a data-driven model illustrating how trauma-related disorders and trauma-related syndromes, some are inscribed in DSM, many are not, interact with a healthcare system. We also need to understand principles of trauma-informed care, processes. What are examples of interventions and how do they address every single layer of the healthcare system? We need a public health framework. We need safety culture. We need metrics, epidemiological data, target outcomes, obsession with quality improvement, effective leadership approaches. So obviously we're not going to do all this today. I highlighted the ones I'm going to try to touch on. The National Coalition of the Homeless has a nice, not operational definition, but summary of trauma-informed care. It's an overarching structure and treatment attitude that emphasizes understanding, compassion, responding to the effects of all types of trauma. So they're acknowledging there are many types of trauma, which is good. Trauma-informed care looks at physical, psychological, and emotional safety, both for clients and clinicians and staff. Provides tools to empower folks on the pathway to stability. So that theme that it's not just patients, but the people helping them have to be equally attended to by a trauma-informed care policy because trauma is contagious. And people who do psychotherapy, the language is projective identification and enactment. In pop culture, we're talking about burnout syndrome and compassion fatigue and vicarious trauma. None of these are inscribed in the DSM, but increasingly they're validated, accepted, and there's a lot of evidence that they're real and that you can assess for them in reliable ways. Oops. So we have trauma, this idea of trauma that needs to be defined, and trauma usually happens in a relationship. Occasionally there's a natural disaster or a freak accident where there is no human relationship involved. But really most trauma involves a human relationship, and most of that trauma outside of war is relationships with people who you're supposed to trust. Okay, so most trauma happens not just in the context of relationships, but in the form of some kind of betrayal, whether it's active betrayal or passive betrayal like neglect. It's really not that passive. And now we have these two fields that branch out from trauma. There's specialty treatment for trauma, which is usually what we talk about. Every talk I've ever been to in a psychiatry conference has been about that, specialty treatment for trauma. Are we doing TFCBT? Are we doing ACT therapy? Are we doing clinical hypnosis? Are we doing ARC, which Dr. Edwards and her team are implementing here? And there's a list, and it goes on and on. And then there's trauma-informed care, which is something completely different. The most common question people ask me when I'm talking to residents or when I'm talking in a place like this, what's a skill that I can do to make my practice more trauma informed? And the answer is that's a trick question because a skill isn't trauma informed care. A skill is specialty treatment for trauma. And when you get into the work, what you realize is that skills only work about as well as the strength of your therapeutic alliance and relationship anyway. There's much more under the surface of a skill than they're usually sold for. So specialty treatment for trauma and trauma-informed care also share this connection to relationships. I don't believe either can be done very well without engagement in relationships consistently and at a high and healthy level. I also want to be clear, this is a deceptive triangle. So trauma-informed care probably looks more like this. We're not going to, this is the book that our department can write when we implement the first major health system, system-wide up and down trauma-informed care. We can write the book and it could be the Maryland model and these could be the chapters. But for now, we'll try to keep things a little bit simple. And each of these terms will have 4 pieces to an operational definition. I just want to plant some seeds early. So is this what trauma really is? This is, people sometimes talk about big T trauma versus little t trauma. I won't go around the whole series of images. Some of them are like stock photos. This one, this boy on the left is Terrell Peterson, who is a famous child abuse not survivor. He died in 1998 while his case was under was actively being supervised by Georgia Child Care Services. And there are many cases like him who tragically died. Medical trauma is something that is not always talked about, but just getting standard medical care, even if you have a non-traumatic background, can be very traumatic. Forced silence, war. This is a mural from India. This is not far. But what I'll propose is that's not what most trauma is. That's what most people think about. And to understand what trauma really is, or at least to broaden our scope, yes, all of these look traumatic, but if we want to understand what it is, we need a definition. And one problem with trauma is that it's really ineffable. If you talk to someone who's actually been traumatized, and you can spend hours with them, you'll never know what it was like to go through the bad thing or the bad things that they survived. And we're at risk of winding up like the dictionary's definition of dance. So dancing, according to Merriam-Webster, is to move one's body rhythmically, usually to music. So if aliens came down from outer space and all they had was a dictionary, they would have no idea about the experience of dancing based on a definition. I propose that trauma is that way too. And it's helpful clinically to remind yourself it's never a good idea to tell a patient, I know what that was like. Because whether you think it was traumatic for them or not, they're going to experience something very differently than you would have. Adversity is easier. Let's start with this one. So adversity was defined in the dictionary as a state of or instance of serious or continued difficulty or misfortune. If you do an image search for adversity, you see a lot of hopeful images, and it's usually white men pushing rocks up hills. You see a lot of those. Adversity is not without comforts and hopes. It was Francis Bacon. We had the famous adverse childhood experiences study. We're going to have to talk about it. Exposure to emotional, sexual, physical abuse, or exposure to household dysfunction. That's the recipe for their famous, brilliant questionnaire. So adversity has to do with exposure to something. This is actually an art exhibit, but I love the picture. Um, there are some famous or well-known and well-regarded individuals who describe trauma, sometimes in colorful ways. John Briere said an event is traumatic if it's extremely upsetting, at least temporarily overwhelms our internal resources and produces lasting psychological symptoms. Okay, good. Bessel van der Kolk once said, an event that blows your mind and leaves you helpless and terrified. So that's trauma with the big T. It's always good to pick on Dr. Robinson, who told me when I was a trainee, something is so painful, you can't learn from it. That's how you know it's true. I always like that. But I still propose we don't have an operational definition. So we can go to some more official sources. The dictionary says it's a disordered psychic or behavioral state resulting from severe emotional stress or physical injury. The dictionary also says, and I actually didn't know this until I put this slide together, an emotional upset. So if you've ever had a patient who had a hard day or heard something from their therapist or psychiatrist that they didn't like and said, don't tell me that, you're traumatizing me. According to the dictionary, they're right. And this is how confused our language about trauma is. The DSM defines it without defining it, okay? Exposure to actual or threatened death, injury, sexual violence, or more through direct experiencing, witnessing, learning, or learning of these events. And a couple of things to note, the DSM really focuses on exposure and its definition, not really anything else. And second, the DSM limits. These are all big T traumas, and it's just a few of them. Most of them aren't in there. World Health Organization says exposure to an extremely threatening or horrific event. Again, it's an event and exposure. The American Psychological says this, and I'll just go to the highlighted words. It has to be a disturbing experience. It has to include an event. It has to also affect a person's view of the world. The only one that's designed for public health purposes is from SAMHSA, Substance Abuse Mental Health Service Administration. And this is the definition I propose, actually, that people keep as a reference. And I hope it will be clear why. So trauma results from an event. It's a series of events or set of circumstances. The event has to be experienced by the person as physically or emotional, harmful, or life-threatening. There has to be an event, it has to be experienced. If the person was in a coma, maybe they didn't experience it, even if it happened next to them. And finally, these experiences and events have to have lasting adverse effects on individuals' functioning, mental, physical, social, emotional, or spiritual well-being. And this is from their 2014 basically brief report on what trauma-informed care is, often cited. And this is a public health focus, because if you are looking to design a public health framework, you need to understand that the events and experiences and effects are not the same thing. They do not necessarily predict the other, and you want to design a system, you want to look at your system to look at them separately and together at the same time. I actually think there's a fourth E, and because we all like the brain, the experienced events have to be remembered for them to be traumatic. So instead of remembering, we could think of encoding. Freud actually picked up on that when he talked about the repetition compulsion. But many of the most problematic traumatic experiences, we don't remember in our autobiographical memory. We remember them behaviorally, and we act out on traumas, especially traumas in relationships. We don't have words for them. Freud actually wrote about this very eloquently in his, I believe it was in group psychology. We understand now they're actually different and neurologically dissociable memory systems. And memory scientists use that term all the time, neurologically dissociable memory systems. So when we talk about trauma, we usually are thinking of a declarative memory, facts, events, and autobiographical memory, semantic memory. But many of the most problematic experiences that we have come out in our relationships with our parents, our friends, and our treatment providers and other people. We act them out. This is a different memory system largely. The memories may be triggered by classical conditioning and emotional memory and then acted out through procedural scripts. This is a good way to start understanding why attachment starts at age 1 and remains pretty constant for most people decades later. The autobiographical memory system doesn't really form, mature until much later. And people with attachment problems are acting out the behaviors they learned with people with the attachment disorders, are acting out the behaviors they learned. And that is going to be true for many people with trauma. This is why big T trauma really misses most of the iceberg. Big T traumas don't necessarily teach us how to act. They cause plenty of other problems, but this is really vital to understand when we work with patients. The patients who give us the hardest times, we call them behavioral. And you hear their history, and often they're like Donna F., who was in foster care and had all kinds of betrayals. Stigma word, behavioral. So if we're looking for an operational definition, we can start to look at it this way. So adversity and trauma can be differentiated by their effects, but in a population, adversity is measurable. And we know this, and trauma may not be. And we know this from the most powerful and elegant retrospective study probably ever done in medicine, called the Adverse Childhood Experiences Study. I assume that everyone here has heard a lot about this. So I'm going to propose what I think is, I'm going to talk about what I think is amazing about the ACE study and attempt to put it in a little bit of a different light than what we may usually hear about. This is the famous ACEs triangle, showing how early life problems lead to early death and disease and other problems. The ACE study, by the way, it's not over. There are fresh and some really shocking results coming out fairly regularly. This study came out earlier this year in JAMA Neurology. This is Wes Welker being tackled by in 2013 by one of the Ravens defensemen in Boston. And I like this picture, by the way, because it's supposed to be depicting a head injury. And one thing we've learned about football is most TBIs don't happen from head hits, primary hits, which often is helpful to remember. So what they found is that dementia risk increases 48% when you control for all the for background factors. Dementia risk in retired NFL players increases 48% when you have an ACE score of greater than or equal to 4. Dementia, poor cognition related quality of life outcomes, depression, and they looked at several others. They were at significantly greater risk of every other neuropsychiatric outcome. So it wasn't the number of hits, it wasn't the number of years played, it wasn't the position they played. It was their exposure to adverse childhood experiences that develops this dose response curve to dementia, which I would not have expected. I found that surprising. Everyone here has seen these long lists of behavioral, psychiatric, and medical problems. A high ACE score corresponds to what I think about when I look at this, especially at the behavioral and medical columns. These are the problems that really clog up our medical system and our healthcare system. Morbid obesity, diabetes, infections. Remember, Donna H. had monkeypox and tuberculosis. Probably because of her social problems, multi-generational abuse, violent behavior, exposure to intimate partner violence, substance use. These are all in the cases that come in our points of care. on a regular basis. Not to mention heart disease, lung disease, and the usual focus of chronic medical disease. But here's for me really what the meaning is of the ACE study. So what's astonishing about the ACE study is the shape you see here. You can find a million slides that look exactly like this. And I like this because most of them don't include 5 because the curve starts to level off. This is actually a dose response curve. The vast majority of relationships you see between adverse experience exposure to this is amazing. Not because it's a dose response curve, but because of what the dose is. It's not a dose of adverse events. It's a dose of adverse categories of events. Those are very different things. And to me, this is really what's mind-blowing about the outcomes of the ACE studies. The ACE, we don't know if there's a dose response curve between events and outcomes. That to me is what's intuitive. This is something more interesting. This is an emergence phenomenon where the number of times you experience something negative doesn't predict. It's something that emerges out of the categories of your adverse events. So there's an ecology of trauma that emerges from the individual organisms that people are exposed to. So an ACE score on a population level, and arguably, depending on who you ask, individual, tells us about someone's reality. It tells us about, so if you go to a random place on Earth and you see an anaconda and an anaconda snake and a lot of trees and monkeys swinging in the trees, all you need are those 3 data points, and you can probably narrow down the regions you might be. You don't need to know the rest of the ecology. The ACE study does the same thing for trauma. You don't need to know how many snakes or monkeys there are in the trees. You just need to know the categories, and you can learn a lot about someone's life. And it's the ecology, not the number of traumas, that gives us a dose response risk-based estimate of outcomes. That is the real meaning of the ACE study to me. And we see it in not everything, but a lot of things. And many of them clog up our health system, which is why I think trauma-informed care is one of the challenges our health system can think about. But we need to go a little further. Do these 4 E's really tell us enough to design policy? I would say not quite. There's a bigger dance team, and it's the I. So traumatic events have dimensions or valences. I talked about betrayal and the element of relatedness. There's a whole literature on this that we can't review today. The visibility of trauma, big T and little t, immensely important. And that's the one I'll talk about in a moment. I just spoke a little bit about ecology. And this piece about the source of trauma is really vital. Sources can come from non-human individuals, groups, organizations, and the biggest is societal, okay? And one of the bitter pills that those of us who trained in specialty treatment to swallow is that most specialty treatment is dyadic treatment, mostly psychotherapy for trauma. But if an organization or a society created events and experiences and effects that are traumatic according to our operational definition, I would propose that one-on-one or similar or group therapy is not matched to treating effects of systemic bias, systemic racism, homelessness, food insecurity, and many of the other problems that actually we know hurt people, and we have more and more scientific evidence to back what many of us have known for years. Dyadic therapy won't help with those things because it wasn't a single person who inflicted systematic racism on someone's experience, or classism, or misogyny, or you name it. So specialty trauma treatment doesn't generally acknowledge this problem, but trauma-informed care really won't go anywhere unless we embrace this systemic, the systemic nature of how trauma can be transmitted. So big T traumas can't be the whole story. What about death by 1,000 cuts? So I just wanted to illustrate a little bit. What does little t trauma look like? Well, it can look like this list. It can look like attachment trauma, traumatic invalidation, microaggressions, gaslighting, victim shaming and blaming, DARVO, deny, attack, reverse victim and oppressor. That was Trump's thing, right? It's not my fault. It's the false media that's after me. We should go after them. We should investigate the investigators. DARVO is really the language of most abusive spouses. You see it everywhere. There's actually a South Park episode on DARVO that is pretty hilarious if you enjoy that kind of thing. And double binds, which is my personal favorite. The double bind is a situation where you have damned if you do, damned if you don't, and there's no way out. And a double bind is what you can boil down child abuse to in many situations. Most child abuse, in most cases, most of the time, boils down to some kind of double bind. So when you read the best book about trauma I think ever written, which is Trauma and Recovery, Judith Herman, 1992 and 4, republished several times. She will talk about double binds and double thinks and double think, and creates really the, if not the first, then a landmark framework for exploring the nature of trauma in terms of double binds. At work, we see it like with this boss. You can make your own decisions, but I'll make sure I check everything first. So that drives people crazy, and that's not even usually what we're thinking about. Emergency room. Every option leads to punishment, no way out. There's a literature, by the way. This is developed in the disability literature. Disabled people in a double bind. If I'm not disabled enough, I don't get benefits and other things I need. If I'm too disabled, I'm stigmatized and everything. I lose everything else. Women trying to get ahead, America and the world, unraveling women of color in STEM double binds. Carly Fiorina, former head of CEO, said, either I'm a bitch or a bimbo, and I succeeded anyway. Haji Oliide, who is a Black management level supervisor at Google, said, you start to second guess yourself in the innate judgment which has guided you your entire life when you're confronted with one double. So it's not just people with child abuse, it's everywhere. And the systemic problems, here we have misogyny and racism in these two examples, take up an enormous amount of headspace for those of us who are lucky and not have to deal with them. Messages children get, if you leave me, and spouses of abusive relationships, if you leave me, fine, but you'll wreck the family, so shame on you. I'll give you something to really cry about. Don't be a slut, but don't be a prude. You can have this thing you're asking for, but what do I get? That's a big one in sexual abuse. No matter what you do or where you go, I don't know, there's no way out. And a huge part of the narrative across backgrounds for child abuse cases is really the kids are the responsible ones in the house who have to cook for mom and dad when they're intoxicated, or who have to take care of mom and dad's needs. All kinds of ways, some you can imagine and some you would never believe. In the ER here, right, we hear stories. I have to go to the police or join a gang, and neither of them are very good choices for me. I have to choose eating or transportation. Kids can do this. Housing or child care. And remember, it's never just the parents experiencing these choices, it's the children in these homes. Psychiatric patients take these trusted medications that your pale-skinned doctor says are going to be just fine, because if you don't, people are going to think you're crazy. And there's a history behind that one. Adopt standards of professionalism that adhere to white supremacy culture, or don't get hired. This is an active area of research. right now in the DEI space, politics of race and class inequalities. And these are all top shelf publications. How structural racism works, double bind of racial and economic inequality in education, race and medical double binds from Columbia Law School. So people outside of psychiatry have more language for trauma than we do. And I propose that that's not our fault. It's because our profession has been systematically blind for trauma until 1980, and then still we never fully caught up. When you talk to people with big T trauma, I like to imagine this, that actually the big T in the room is the giant T made out of lots of parts. This is how people with big T trauma describe their lives. It's the giant little T where the acting out that cause codes in hospital units, in trauma survivors often. You could think of a trauma survivor's life as being a quilt where the things you can see are the big T's, but the stitches in the quilt that hold the patches together in the way they do are little T's. The little T's don't come out in a content-based history, they come out in the process, and they come out in how you feel with the patient. On a systems level, they come out in burnout, they come out in secondary PTSD and compassion fatigue, they come out in staff turnover, which is a metric we can measure. Specialty treatment for trauma involves specific disorders, has individualized aims. There's a whole list of evidence-based treatments we've all heard of. They're complex syndromes that are actually being studied more now than they were. And what I wanted to mention about PTSD is it's really not just a disorder. This is another cognitive error that our field has made, and it goes all the way up to NIH funding. If you hear about trauma research and the brain, about cortisol system, HPA axis, and the amygdala, circadian rhythms more than anything else. But fear is only one piece of the disorder, and in patients with the highest level of problematic psychopathology, it's often the smallest part of the disorder. If you really want to understand trauma, you need to understand that the shame system is highly involved, and there's a burgeoning research on the shame, on the psychopathology of shame, which is transdiagnostic. Shame also doesn't conveniently hang out in brain structures because it's a lot newer than fear. Fear's been around probably millions and millions of years. Shame is what pack animals experience. It's a lot newer, and we may never find a home for shame in the brain. We talked about the ecology of adversity, and patients with trauma, when you really speak with them about their trauma, you'll find out they're living in dual realities or multiple realities because their PTSD keeps their past from becoming history, and they have reality testing problems. So in the old psychoanalytic literature, many times, like when Winnicott wrote about psychosis in a famous essay about hate and the countertransference, he was talking about a traumatized child. Just to add more to the rich language, interesting language problems. The alternate reality disorder, this is a flashback I liked from Disney Pixar Ratatouille. This is usually what we think of with flashbacks, but I propose to you that flashbacks are a little more interesting than that. Shame, by the way, is also problematic in an assessment because people hide it. So we avoid it with sex, drugs, and rock and roll. We go away where no one can see us. We self-harm. And we attack other people, like the cowboy who has to defend his girlfriend's car. These people aren't saying I'm ashamed inside. These are defenses. But these are the presenting faces of people with shame. So if someone comes in, saying, I need help because I'm so ashamed, usually that often means I'm too healthy to really need help, but I'll have a conversation with you anyway. This is what shame looks like. It doesn't usually look like someone talking about their shame. They might come in talking about their fear, but that is much different from this. Judith Herman wrote a paper, not famous enough of a paper, called PTSD is a Shame Disorder. It's wonderful. It's full of data that everyone should know. So the most brilliant film depiction of complex PTSD is this film, The Five Bloods, came out a couple of years ago on Netflix. This is Spike Lee film. This is Delroy Lindo, who does a brilliant depiction of a patient, a character called Paul, who spends the film. This won't ruin the film, but he spends the film turning the present into a recreation of his wartime experiences through the kind of acting out behaviors that I was mentioning. He also has some traditional classic PTSD symptoms. I've learned that most people in training haven't seen this film, but I've seen this film. Good Will Hunting has a famous scene where Matt Damon is in therapy with Robin Williams, and he turns Robin Williams into his abusive dad. And if you've seen this film, this might be one of the most memorable scenes where he really gets under Robin Williams' skin and in enactment and projective identification. Robin Williams jumps on him and finally, thankfully, comes to his senses and says, okay, well, time's up. and then things get better. So these are flashbacks. This is a behavioral flashback. And this is what PTSD really, from people with the highest degree of psychopathology, is often about, and for which prazosin has never been tested, and I doubt will ever show efficacy. But PTSD is far from the only trauma-related condition, as I've alluded to, but also something's happening in our field with trauma and psychiatric diagnoses. So look at the point prevalence of our major diagnoses, right? We have schizophrenia. They're all in the 0.3 to 0.6% range. Bipolar disorders combined 1.8% range, right? But if you walk into many of our sites, certainly emergency services, but not some of the outpatient services too, you'd think everyone homeless in Baltimore has all of these, right? PTSD has a point prevalence that's bigger than schizoaffective disorder, bipolar, all the bipolar disorders combined. The thing about PTSD, though, is it can mimic them, which is something I was not taught in my training. It can mimic schizophrenia, including all the negative symptoms and disorganization. This is another active area of discussion. A few months ago, Heather Hall put out dissociation and misdiagnosis of psychotic disorders in populations experiencing chronic discrimination and social defeat. Social defeat is interesting because it's a systems level trauma-related syndrome that's increasingly being studied. I promise I did not make this up, and I did not have to sift through, I did not have to select any articles to find this data. Across the board in psychiatry, I want you just to see the diagnosis rate of PTSD and the underdiagnosis rate. It's not underdiagnosed by 10% or by 50%. It's underdiagnosed by more than 90% in addictions clinics. If you these are all involving hundreds of patients. 36% point prevalence for addictions is closer to 2/3 lifetime prevalence. 2.1% of the patients in 11 clinical sites had a charted diagnosis of PTSD, when 30% had a point prevalence on screening. Inpatient psychiatry, similar ratio. Outpatient psychiatry, similar ratio. Community health, I put a star because CMHCs are disincentivized to diagnose PTSD because they don't get paid if PTSD is the primary diagnosis. And that's important to know about. So the primary care doctors are actually doing better than any of us on a systems level. Yeah, because they have not been socialized not to think about trauma, is what I propose to the panel here. They're still not doing great, but the psychiatry field is really unique in its blind spot, not only for PTSD, but for what PTSD really is. And if we're going to take trauma-informed care seriously, we need to own this. The things to understand about CPTSD is that most patients presenting for treatment seem to have it. This is a brand new literature because complex PTSD doesn't exist in the States. It only exists everywhere else. World Health Organization did the validation, and it's adopted in Europe in the ICD-11. Most people who present for treatment don't have PTSD. They have another validated condition called complex PTSD, which on the whole means your symptoms are going to be more severe. You're going to respond less to specialized treatment. You'll have a prolonged treatment course requiring phasic years-long treatment, greater comorbidity, greater functional impairment. So when you diagnose someone with PTSD, you can't give them a CPTSD diagnosis from the DCM, but there's a good chance this is where our field needs to go. CPTSD is mainly developmental. Okay, so interestingly, general population, you see the numbers are much closer, but in treatment presenting populations, complex PTSD far more common than non-complex PTSD. So here's our trauma-informed intervention. You can do a PTSD screening thanks to Dr. Rockweisel now faster than a COVID test. You can use the PTSD-5 validated in 2016 with a strangely high sensitivity and specificity. I think this is worth a revalidation study and community sample. If anyone wants to work on that here, we should talk. There's a dot phrase that Dr. Rockweisel was able to move through the EPIC team. It takes less than a minute to do this. Patients tolerate it extremely well. There are no triggering questions. They're all yes or no. And we have good reason to believe that this can give you good information where we're not getting any. So you can do this at intake and you don't have to ask someone's trauma history. Faster than a COVID test. So PTSD alone can be thought of as a public health problem. And it's common, it has all of these problems. Its prevalence is higher than many of the conditions we're all socialized to think about the most. But the public health piece is that it's preventable, it's treatable, and it's systematically underdiagnosed, which is why I appreciate the chance to think about it here. I need to skip ahead and wrap up in just a couple of minutes, but I want to just make it clear that PTSD alone is just a piece of this because most trauma syndromes are not PTSD. Trauma-informed care is generalized. It assumes people walking in the door have trauma. That's different from specialty care where you do a diagnostic evaluation. Oops. We're not looking at just disorders. We're looking at syndromes, traumatic processes within an institution. What's the safety culture? What's the Title IX policy? How well do we adhere to it? How well do people feel heard? And there's a literature in organizational psychology about this and how feeling heard improves people's work-life balance and work happiness and probably reduces turnover. Who would have thought that listening to people you work with makes a difference? The aims are systemic, they're not individual. It's a low threshold model, not a high threshold model. And there aren't evidence-based treatments where we need our evidence-based approaches. And what do we have? We have to have goals for trauma-informed care. And here's the operational definition that we might build on. It has to protect patients from being hurt again. And really everyone involved, because if our staff turns over, we have to train new people and we'll have a staff that's chronically confused about what we're doing and unable to work well with traumatized patients who compartmentalize their experiences as a coping measure. We need to prevent reactivation of trauma-related symptoms wherever we reasonably can. Sometimes we can't prevent it during a code. If someone's been tied down and hurt, a code to protect their safety is the most compassionate, safe thing you can do. And it will probably re-traumatize that person and activate their trauma scripts. 3 is to promote a healing environment where people can actually heal. And 4 has to do with surveillance. These are the operational components of a potentially functional trauma-informed care approach. And you hear most famous are these principles. These principles aren't really operational. They're more like humanistic medicine ideas, which are good, and they inform more operational ideas. So it took about an hour to get to operational definitions. There are a couple of approaches that are published. This is all brand new. None of this, almost none of this, it really has clinical evidence base behind. And the evidence base is difficult to develop because it takes years. And because evidence-based medicine is designed for individual treatments, not for systems. So we need to think in a different way from how we've been taught and socialized as physicians if we're going to take trauma-informed care seriously in a research capacity in addition to implementation. What we do have is another form of public health system that we can think about, which is infection control. We think about vectors, modes of transmissions, pathogens, reservoirs. These are all isomorphic and analogous to processes that happen in trauma. We have standard precautions. What are the standard precautions for trauma-informed care in a large healthcare institution? What are the habits that we need to counter systemic bias? Remember, we can't cancel racism. We can't cancel bias. A once-a-year training about bias or education about racism is autobiographical memory. We need procedural memory in order to take a serious shot at this, not just on the individual level, but the institutional level and systematically. They have those procedural memory pathways. In nursing school, you learn standard precautions. Look at, this is just a list of all the different diverse ways that we think about infection control on the microsystem, the individual, the institutional, the societal, the public health campaigns about COVID and HIV. These are all part of infection control policy. This is so vast. No one institution can do this alone. We need partnerships. This is the part I like. Infection control, you need to know every single bug that could infect someone at any single point of care. And if you sign on to state healthcare websites, they have these lists. So why can't we have a list like that for trauma? Maybe it would look like this. We can't possibly screen for all of these conditions and experiences and syndromes in an individual assessment. Syndromes of self-harm, vicarious trauma, burnout, compassion fatigue, moral injury is a big one in the VA. Child and adolescent have diagnostic categories too that we don't see as much in adult. And the important things to understand in the analogy, and I'll have to probably stop in a moment, is that the vectors for trauma are the levels of the system, as opposed to someone carrying a virus in their body. The vector for trauma is the individual person or the group, or it's the institution, or it's the society. So interventions need to be scaled to the vector in a trauma-informed, in an operational approach to trauma-informed care. Here's an example of mismatch. I already mentioned systemic racism probably ain't going to change much with dyadic psychotherapy. Even if someone's chief complaint in psychotherapy is, I'm a big racist and I want to change. That's probably not going to work. Transmission occurs through behaviors on all levels. Disease manifests through not just disorders, but syndromes. And healing becomes possible through relationships. Trauma starts through promotion of dignity and interventions that match the vectors. There's a growing literature on dignity and trauma-informed care as well, including dignity in health systems that I am excited to see coming out. This is the last thing I really wanted to make sure we discussed. So has anyone here heard of HRO? Okay. Has anyone here taken the SCORE survey that went out here recently? That's what this is about. So this health system is already investing millions of dollars into principles of high reliability organizations. Okay. And what I propose is that HRO is really central to understanding part of the systems approach and institutional approach to trauma-informed care, because traumatized patients are constantly dealing with overwhelming shame and they cope through disconnection. So they have different kinds of relationships with different providers. This creates interesting problems or questions for a system that relies on specialist referrals, because what we're doing is pushing people into different relationships with strangers, perhaps sometimes when we don't need to. And there is a cost to that if you are thinking about trauma. There is a cost to referral, no matter how good our intention when you think about trauma. Also, staff has to be extremely well versed at how to communicate and how to take care of themselves and prevent burnout and maintain boundaries. HRO also, I like it because they really pay attention to how complex systems of people are. You can't just activate a plan like a basketball coach or a military general. It doesn't work, and there is a literature to show that. Trauma-informed care needs to think about these. So a high reliability organization has a validated metric called the SCORE survey, which we all maybe took. That's for about safety, communication, operational liability, and engagement. And I propose these are really most of the fundamental ingredients you need on a team for engagement, prevention of burnout, and reducing turnover. And being able to tolerate working with a high volume of traumatized patients day in and day out without becoming affected too much by the acting out behaviors you're experiencing. There are other assessments. There are burnout, many validated burnout assessments, work-life balance assessment. There's a feeling heard assessment. I should probably stop here, but we can start thinking about what interventions could be and include and look like. This is about habits and what trainings need to involve. So if we want to take a serious shot at dealing with shame, stigma, racism, misogyny, ageism, classism, training needs to be continuous, and it needs to instill habits on all levels. What are the standard precautions that we really need for trauma-informed care? So I just wanted to remind about Trauma Donna F and how maybe the future Donna Fs of the world can experience healthcare anywhere they go, maybe a little differently than they have before. Thank you so much.
We're going to take questions. We're going to take questions. Yeah, just stand right here. Okay, thanks, Ben. Thank you, Ben. That was fantastic. We can take some questions from the room, and we can also take questions of folks online. We have two things in the chat. For people in the room, I'd ask that you use the microphone so that the people remotely can hear the question, and then we'll have Ben address your question. So we have 90 people online, and those of you in the room. So if you have a question, Jane, I see you approaching the microphone. Go ahead.
We're always this way.
One of the concepts you mentioned and that you and I have talked about before is the idea of treating patients with trauma in an environment that is safe. Oftentimes in our community clinics, we can't ensure that the patient's environment is safe. We can't necessarily get them out of the environment. And so when I see people in the community clinics who are often diagnosed with schizophrenia, and there are times when I think, I think that psychosis is more related to trauma than it is to schizophrenia. Sometimes the people don't even realize that whatever they have experienced in their life has been traumatic, because it's like, this is water, kind of what they've lived in. And so then I sort of feel like you're in a spot where do you tell someone like, well, you've been traumatized multiple times over the course of your life, and that's why this is happening. And you're still being traumatized now, and there's nothing I can do about it, but I don't think you have schizophrenia. That, I guess, that's sort of where I'm stuck is what is, I guess, most useful and kindest to the patient in that scenario.
And that Jane, I'm like struggling with that one too. And I think I have actually, just if this will go back a slide, I'm struggling with it because I mean, you have a brief conversation with someone, and many people are allergic to the word trauma. It's the last thing they need, and they may have an identity organized around surviving. You don't know. And so how can we meet people really where they are in a brief amount of time without offending them or making them not want to come back, and also be real about what's going on? And I think the reason that's hard is that the biggest obstacle to treatment of trauma in many of the patients we treat is homelessness. That's the problem. And I put it at the bottom, comprehensive addressing. It's a macro problem, a meso problem, a micro problem, and our society has collectively decided not to solve it. And we're swimming in all of the secondary effects of, I think you're describing maybe homelessness, but living in a really violent, difficult area and that is analogous to that problem. And the answer isn't more police. We learned from social science a long time ago. And we can't really say that it's hard to tell someone that, to explain that to someone. And I attempt to be problem focused and to really listen to what someone's saying. And I find that to be the most helpful approach. Part of how we're socialized in medicine is this hierarchy where the doctor's up here and the patient's down here, and I explain to the patient their problem, right? But do you see how not trauma informed that is? Because that's how people get betrayed and hurt at home and institutions and so on. So even trying to do a helpful thing and explain that you don't have this stigmatized psychotic disorder can have you step into a flashback of someone being gaslighted or talked down to. And it's very difficult because we like to think of psychoeducation as a benign intervention. It's not. It has certain risks. And probably all of us have been kind of unpleasantly surprised when we thought we were giving someone some helpful, really useful, critical information, and they threw it back in our face. And that has to do with partly how we're socialized as physicians. This old school Eurocentric white superiority culture model where the doctor who knows everything and is punished if they don't know everything talks down to the patient. So I really try to take a step back from psychoeducation and listen, and that is so hard. That is psychological work, and sometimes it helps, sometimes it doesn't, and you know, if someone identifies for whatever reason with their psychotic diagnosis, psychotic spectrum diagnosis, then I try to honor that and build a relationship that I can. Does that answer your question? Yeah. Okay, maybe we can keep our conversation going because you're one of the people I'm hoping actually to learn a lot more from in this space because I'm new to it. Thanks, Janie.
Actually, there were multiple thank yous in the chat, but no actual questions. Anyone else have a question for Ben? Maddie?
So for the past 10 years, I have. Oh, hi, it's Madeline Marks with our CL division, psychologist. And so, for the past 10 years, I've spent my time in developing expertise in treating people with virtual reality, as well as educating and doing research in those that have trauma and stressor-related disorders amongst mass and community violence. And so now with our shock trauma initiative, so to follow up with what you were saying, is that, do you see our way forward in partnering with others as being in the terms of trauma-informed care of acknowledging, respecting, and integrating people's cultural beliefs and values, especially here in our populations, especially that what I'm seeing on shock trauma, those who are just inundated with what we in our ivory tower might call trauma, but they call everyday life.
So, yes. So the question is about how do we engage systematically, Dr. Marks, about how to talk with people about their experiences? Okay. Well, we need new habits, and this is a systematic, another really hard example. I'm waiting, of how hard it is to change how we think and speak. to patients. Once we're out of residency training, where most of us set in our ways, especially if your focus isn't language, and most of medicine doesn't focus on language like psychiatry does. That's one of our strengths, and especially psychotherapy. It's really hard to change those habits. When their whole life is big T trauma, even then there's a quilt with lots of little T's stitching those. And if you start out in the middle of the ocean, it's going to be a while, no matter how hard you work till you reach the shore. And that's hard, I think, for a lot of clinicians to sit with. It is a huge, one thing we don't talk about enough is how much psychological work it is to work with these syndromes, with these patients whose whole life is trauma. That's why I feel helpless so much of the time myself. And I'm supposed to have experience as you do, because we have a psychologists, at least 2 in the room here, who are also trauma specialists. And I never went to psychology school, but I feel helpless all the time. And that is hard. That is a hard kind of psychological work to do. I suspect that's part of the reason why it's hard to do therapy at a place like this, among other facets. Engagement within a team is probably where things need to start. Engagement and communication across teams is the next level. Dr. Mike Robinson and Rockbeisel know more about that here than I ever do. Language is hard, and it is psychological work, and we're socialized to take that for granted because of this training in Western medicine, where the doctor is supposed to be like a god almost. We get pimped and punished if we don't have the right answer. And part of this is I wouldn't say unlearning it. I don't think we can cancel that culture. I think we need to learn new habits, though, to counter it. One of the hard things about both of these questions is I don't think there are tricks. I don't think there are shortcuts, because this is about relationships, not just with our patients, but with each other. And I think there are really two sides of a coin. I think team-centered care is the same thing as patient-centered care. And when we sometimes hear that the problem with this team is it's not doing enough patient-centered care, often what it means is the team also is hurting. Yeah.
So I'm going to just make a quick comment on this as well. I was thrilled that you brought up an HRO, because the University of Maryland medical system, with the center leading the charge, has adopted the mission of becoming an HRO. We have all our scores back, both for our department and the entire organization, and they were just released 2 weeks ago. And I have them, and Ben, I'd be interested to look at them with you, but all of the leaders will get copies of it. And it really is about, some of it is, psychological safety, teamwork. I mean, I think there's so much embedded in this that our department could lead the charge on that aspect of it. So it's very exciting to think that we on a macro level can make a difference. It's at 1:30. Catherine, I see you have if you could make it quick, a question, and then we're going to stop there. So you have the privilege of the last question.
Really wonderful talk. I appreciate that you talked about the complexity of trauma for both folks who are patients and then care providers, because they're all experiencing some trauma. They're just sitting on the other side of the line. You working in the hospital setting, in the ER, or on the CL service, or on inpatient settings, we often are face to face with like the most acute patients. And I really worry about our healthcare workforce. Like 20% of healthcare providers left their jobs during the COVID time. Like about 45% of nurses, if surveyed now, are thinking about leaving their job in the next couple professions. We're having really key people sort of like walk away. And and it is exhausting. And there is this moral injury when, especially if you're in environments that are not optimal. You know, when patients are in a room that looks like a prison and, you know, there's urine on the floor and like hard plastic chairs and there isn't a place to be and they scream at you, this is not helping me. This is making me worse. And they're right. Right. But like, I don't have anything better to offer them. That is really, really hard. So I applaud the bravery of the department for like thinking creatively about this, because in medicine, we're often just suck it up and like take a big breath and then just keep on going. And when you do that, you lose your ability, I think, to be a compassionate and effective healthcare provider, because you lose your diagnostic skill and you lose your sensitivity. And in psych, you know, like in cardiology is easy. You have an echo, you put it there, you see it squeeze. It might be harder to fix it, but you know what's wrong. In psych, we are both the tool of diagnosis and the treatment instrument, right? So like if we're hungry or angry or lonely or tired or burnout or racist, we are inaccurate and we fail. And I think we really have to think about that. And like, it costs money to fix these things, but it also costs money to not. And that's medical errors, and that's people leaving, and that's people dying.
Thanks, Dr. Harrison Ristelli. As usual, beautifully said, and I love working here because there are people who are thinking like you and Dr. Marks and Dr. Richardson and many others here who care about relationships and who try to make the best of an imperfect system. One of the first things I often say in PES is, yeah, this is a hard place. And that's on us. It's not on you that this place is not clean right now. It should be, but it's not. And a lot of times that helps, not always, but it does help to actually name the thing everyone can see but ain't saying. When someone is like one of those fish and they've been swimming in trauma and can't see it, Dr. Richardson and Dr. Marks were mentioning, you can feel it. One of the hardest principles of psychotherapy supervision that I haven't figured out how to teach is that a lot of psychotherapy, your biggest instrument is your body. You feel what the other person is trying to say, but you don't know what the words are exactly. And we feel that in this work, though we're often not thinking in the psychotherapy framework. And we feel it on teams, and we feel it when we get, not the Microsoft teams, but in our clinical teams, and when we go home and and other places. So thank you so much for these comments and for having me.
Do you have 10 more minutes? One of the benefits of being in person is you can come up and meet the speaker. So if there's anyone here that would like to personally introduce yourself to Ben Israel, Dr. Israel, and you make a plan to talk further, please come on up. Thank you all for coming to Grand Rounds.